A 54-year-old man comes to your office complaining of long-lasting fatigue that has been increasing since 6 months ago. He exercises regularly, but he notices shortness of breath recently while jogging. He also notices occasional joint pain for which he uses NSAIDs like ibuprofen sometimes. He denies any other symptoms like bowel change, paroxysmal nocturnal dyspnea, nausea, vomiting, fever, and weight loss. On examination, there is a slight pallor of the conjunctiva and skin. No lymphadenopathy is noticed. Thyroid has normal size and consistency. Cardiopulmonary examination is completely normal. The abdomen is soft and non-tender in palpation, and no hepatosplenomegaly detected. His peripheral pulse is normal and symmetric, and there is no cyanosis, edema, or clubbing in extremities. Now it is time to make a decision for managing this patient and answer the following questions. The first one is, what is the most likely diagnosis? The second one is, what is your next diagnostic step? And the last one is, what is your treatment plan? We suggest you think a bit about these questions first, then keep on watching the rest of the video. Now let's answer the questions and manage this patient step by step. When someone complains of exercise intolerance or decreased respiratory capacity for several months with no obvious reason, the most likely diagnosis is iron deficiency anemia, probably as a result of chronic blood loss, despite of what is the physical examination. So we need to order some tests to confirm the diagnosis. The next step is to check the hemoglobin level, RBC count, and mean corpuscular volume to find out if there is anemia and characterize its type. So we order complete blood count in the first step. The laboratory gives you the result after a while. Here is the result. White BC count is 6,400, RBC count is 3.2 per microliter, hemoglobin level is 8.4, MCV is 71, MCH is 24, and platelet count is 288. The serum hemoglobin level confirms the diagnosis of anemia. Now look at the mean corpuscular volume, that means the average size of red blood cells. As you see, it's below the lower limit and shows the small size of red blood cells. So the type of anemia is microcytic. There are three types of anemia based on MCV. Low MCV number or microcytic anemia is possibly seen in diseases like iron deficiency, thalassemia, and lead poisoning. Normal MCV in patients with anemia lead our mind to conditions like hemolysis, acute blood loss, anemia of chronic diseases, and myelodysplastic syndromes. Macrocytic anemia is usually seen in vitamin B12 deficiency, folate deficiency, alcoholism, and drug toxicity. The most common etiology of iron deficiency anemia is blood loss, and the most likely source in men is gastrointestinal tract. This patient is using ibuprofen that can cause inflammation in the gastric mucosa and predispose to gastric bleeding. So complete evaluation of upper and lower gastrointestinal tract in this patient is necessary. Here is some of the common causes of iron deficiency anemia. Blood loss, especially with gastrointestinal source, reduced iron absorption in patients with history of gastrectomy, celiac disease, or inflammatory bowel disease, and inadequate dietary intake, like in those who are on vegetarian diet. The usual symptoms in patients with iron deficiency are primarily due to anemia. Typical symptoms include fatigue, exercise intolerance, exertional dyspnea, weakness, headache and dizziness, and in severe form, patients may develop pica, means craving for paint, ashes and chalk, or pagophagia, or craving for ice. Sometimes patients might remain asymptomatic. It shows their body is able to adapt to lower iron reserves. Regardless of the presence of the symptoms, all patients with iron deficiency anemia should be treated. And the more important issue is to find the underlying etiology. The choice between oral or intravenous iron replacement is depends on some factors, include acuity of the anemia, availability of the iron products, and patient's ability to tolerate oral intake. In these patients, we prefer to start oral treatment because the patient is hemodynamically stable, with no dangerous signs and can tolerate oral medications. Correction of anemia usually requires 6 weeks and sometimes less, but the treatment course should be continued at least 6 months to replenish iron stores. Numerous oral iron formulations are available, like ferrous sulfate, ferrous fumarate, and ferrous gluconate. The recommended dose of treating for iron deficiency is in the range of 150 to 200 mg per day. For this, we can prescribe 325 mg of ferrous sulfate 3 times per day. 3 tablets daily will provide 195 mg of iron for body. It is better to take iron supplements during the meals to prevent some complications such as constipation and nausea. Once treatment is started, it is best to check the complete blood count and iron panel 3 months later to assess the patient's response to treatment.